And now it's time for our plenary 3. This session is entitled Asia Pacific Delivering Compassionate and Humanized Healthcare, Putting People, Communities, and Society at the Heart of Healthcare.
Well, this session is going to be moderated by Cornelia Medina, Program Officer, the Max Foundation. And our speaker is Kun Ranjit Pritam Singh, Board Member, Reach to Recovery International Malaysia. And I understand initially on the program, Dr. Shams was going to be here. Unfortunately, he cannot. And Kun Kawaldip our CEO, the CEO of IAPO, will substitute for him.
As always, you can find our speakers' full biographies on the 4th Asia Pacific Patients Congress page on IAPO's website.
Yes, and as yesterday, before we get started, we invite all of you to submit questions to our speakers, whether you're attending in person here or online. For online attendees, please send your questions via the Q&A tab by the virtual stage. And now, I invite Cornelia to take the floor. ขอบคุณครับ
ขอบคุณค่ะ
Oh my God, you don't want me to talk today. Okay, thank you Titi Porn and Kwan Chanuk for the introduction. Good morning and welcome to the session entitled Delivering Compassionate and Humanized Healthcare, Putting People, Society, and Communities at the Heart of Healthcare. May I call on our 2 speakers to please join me here on stage. Ranjit and Kawaldip, please. So this is not working. Hello. Good. Can you hear me? Is this working now? Hello? Okay, so now it's working. Now you can have this.
Okay, thank you.
Okay. So this morning we have 2 expert speakers who will help us understand the meaning of humanized healthcare and how they have been able to implement this in their own settings. We encourage our online and in-person participants to please send in your questions during our Q&A portion. So let us get started. Let us listen to our first speaker, Ranjit Kaur Pritam Singh, who is a board member of Reach to Recovery International in Malaysia. I hope I said it right, Ranjit. Ranjit will share about the international experience exchange with patient organizations' position paper on humanizing healthcare, a call for transformational change. Our post-pandemic Build Back Better efforts can be enhanced by applying the best practice and principles shared in it. Over to you, Ranjit.
Forward. Okay. Yes, I know, but there are some things I cannot see. Do you? I don't need. Hi, good morning, everyone. I know it's day 2. It can be difficult sometimes. I would first like to thank the organizers for inviting me to speak here. And thank you for introducing me. So my paper is on humanizing healthcare, a call for transformational change. And it is the IAPO, or International Experience Exchange for Patient Organizations. And this is our position paper. So a little bit about IAPO. The International Experience Exchange with Patient Organizations was formed around an objective to provide a collaborative environment for pivotal discussions around key topics on the patient agenda. So most of the time you'll find that agenda is usually belonging to healthcare providers, policymakers, but patients are not part of the conversation. So in this case, patients took action to be part of the conversation. So IAPO is actually a platform for patient communities to be strong and impactful partners and participate with an equal voice in the healthcare system. And this patient-led initiative offers opportunities to exchange experience, to find ideas and inspiration, and leave with practical, meaningful, actionable, and usable ideas that can be developed in a co-created way among patients as well as healthcare providers. But in this case, the dominating factor is the patient community. Now, IAPO is sponsored by Roche and is organized in partnership with independent and an external advisory committee of global leaders in patient advocacy. So Kavaldeep and I are both members of the external advisory committee. So about the position paper that I'm going to talk today on humanizing healthcare, it is based on the idea of putting the patient in the heart of healthcare. And under WHO's meaning, it is compassionate care. And humanizing healthcare actually means rebuilding healthcare systems around the needs of people, the people who need the services. And this paper analyzes specific calls to action of areas that are urgent and the need of action by the IAPO community and the contributors of the paper. So actually, what we have is we are looking at policy change within our countries and to develop more resilient healthcare services and ecosystem for patients, it is patients, healthcare industry, and policymakers that can come together to discuss how the year for patient-driven action in multiple interactive sessions that can take place. Now, the IAPO is organized in 4 key domains of engagement: think, learn, change, and make. So if you go to IAPO.com, you will actually find all the details. You'll find toolkits, resource materials, as well as examples of how you can do humanizing healthcare. So try and go into that. Now, what I would like to talk about here is that the position paper consists of an analysis of certain areas that the IAPO community and contributors see as pressing and in need for change. And most importantly, this paper contains specific calls to action that sit within each chapter. So what we have is, we have 5 sections: putting people at the heart of healthcare. We have humanizing health literacy, humanizing digital healthcare to build capacity by harnessing the power of patient data, humanizing healthcare to focus on prevention and cure with a new 50-50 model, and also prioritizing diversity, equity, and inclusion to humanize approaches with healthcare. So it is important to take into consideration that one model doesn't suit everyone. We are all different, so we need that. So the main author, Thomas Beresky, actually says, humanized healthcare means putting people and patients at the heart of healthcare and broader cooperation across patient groups across the world. All stakeholders need to work together to understand and steer the informative process through data. You can see the entire paper in the IAPO.com. So why is humanizing healthcare important, urgent, and we are creating a global call to action? The paper represents the needs of the patient community, as I mentioned it before, when it comes to healthcare decision-making and transforming the healthcare ecosystem within our own communities as a result of inadequacy, insufficiency, and underlying systemic problems. So we do identify some systemic problems in our healthcare system, and that is why we talk about how can we make the change. Now, what are the challenges? One, heavy focus on secondary care. Two, lack of health literacy among the general population. Whatever the healthcare services or providers are talking about, nobody can understand. We just nod our heads. And it's particularly very common in Asia-Pacific region, particularly in the Asian region. When the big guy talks, you just nod your head, whether you understand or not. Lack of clear and universally accepted data collection and management principles. An inability to flex the need of increasingly diverse populations. We tend to forget that there are people out there who don't understand the healthcare system. They may not be introduced to it. They may have their own way of working around their healthcare. They may have their own beliefs and their own ways of overcoming the issues that they face in terms of health. Challenges in diversity, equity, and inclusion. Are we including everyone? If yes, is the language suitable for everyone? Does everyone understand, or is it only the domain of the healthcare providers that need to understand? So that's what humanizing healthcare is about. So what is the solution? We had lots of discussions. We need compassionate and sustainable healthcare system. When it is done correctly, the system activity achieves actually better economy. It is not considered an expenditure or spending on patients. It is considered an investment. And that is where we lead to cost saving as well. And healthier populations as well. We have found that many of our countries do not have economists in the healthcare services. We just have healthcare providers. We just have medical people who are medically qualified, but economically may not be qualified. And so to get a healthier population, you need economists to be involved as well. Humanized access to everyone and parity of health across the globe. That is what we need as well. So the other thing, of course, is empowered patients who take ownership of their own health care. Why do we need to own our own health care? We need to be literate in our health. We need to be able to prevent diseases through lifestyle changes. And if we don't have a communication and conversation with healthcare providers, we will not know what to do. We may be influenced by advertisements out there, which may not be really suitable for us. And we may also be influenced by our ancestors who have certain beliefs. So the key calls to action that we had in the position paper included a focus on the need of humanized healthcare for patients and healthcare providers and ensure joint decision-making. So shared decision-making needs to come into place in our countries. And also, we need to provide holistic services to the patients to sustain the services as well. If we don't trust the healthcare services in our country, we will underutilize them, and that's when the budget will be also underutilized and it will be misconstrued as we do not need certain services or we are living a normal life. So this is for all. When it comes to patients, it is facilitating conversation with healthcare providers and educating healthcare professionals about the need and value of compassionate care. That we are human beings, we are not diseases. And we human beings start as healthy human beings. And we need to communicate with them. We need to understand them, they need to understand us. And we need to speak the same language. Generate data and share insights with both public health authorities and industry on the value of patient data. We are entering the door. We're putting our foot into the door of the healthcare services, and we want to be more actively involved. What can governments do? Drive synchronization and rebalancing of care between primary and secondary services. What about healthcare providers? This includes healthcare professionals, payers, policymakers, and stakeholders across the pharma, as well as education and IT industries. And they can develop strategies that address the challenges in achieving health literacy and working together to improve digital literacy and close the digital divide. Now, they can also champion responsible, inclusive. I'm sorry, I cannot see very well. I cannot see the screen very well. So I will need to read from my computer. So working together to improve digital literacy and close the digital divide as well. And as well as champion responsible and inclusive innovation and enable equity of access in addition to privacy and transparency. So there are responsibilities that were created by the patient groups, the patient leaders from EAC, and this is what we came up with. So what we are talking about is, our goal is action, not just talk. So change won't happen overnight, but if we unite for change, we will be able to transform our healthcare systems together. So a survey was done there were 3 key questions that we put out globally to the people, as well as we had results from the Asia Pacific region as well. So the first question was, to what extent do you agree with this statement? Individual patients' needs are recognized and are treated with compassion by the healthcare providers in my country. So we had 59 people who responded in the Asia Pacific, and globally we had 304. So you can see here, globally, 37% says, I don't agree with this statement, 34% says, I agree, and 22 are not sure. So why do you have people who are not sure of it? Because they have never realized that we should be treated with compassion in our countries. And the next one is, to what extent do you agree with this statement? The healthcare system in my country is working to decrease the unfair and avoidable health differences, such as access, resources, and outcomes people may face because of race, religion, gender, disability, age, sexual orientation, and socioeconomic background, including even geographical distances. So 11% strongly agree, 36% agree on the global perspective, and 21% disagree. So there again, you can see that people are knowledgeable that there is a decrease, but 36% is a bit low, isn't it? 36 plus 11%. So this is actually, when you look at it globally, it is largely from the high-income countries. It's from the European and US areas. And then you have, sorry. To what extent in your opinion, does your country healthcare system provides universal health coverage? And the definition was given to them as to what universal health coverage is. That is, all people receiving health services they need, when and where they need them, without suffering financial hardship across the life course. So you can have, you can see the results, 47% said no. And that's very significant. So in conclusion, I would like to say, instead of a top-down approach, we need to have a meet in between. And there should be a collective community involvement, because all of us in the community are stakeholders. It should not just be involving individuals. We need to involve organizations as well in the community that may not be directly related to healthcare services and may not be recognized as part of the healthcare services. But when we're talking about addressing individuals, addressing people, addressing communities, communities have units, they have organizations. They're organized already beforehand. They may be organized in religious groups, they may be organized in social settings, they may be having their own community organizations where they provide traditional services to their own people. They may be having community-based groups that discuss the things that are important to them. And palliative care homes that are coming up, care areas that are coming up, schools that are coming up. And I don't understand why. I remember at one time when I was in school, I'm very old, yeah? When I was in school, we used to have health education. I'm not so sure if it's still there right now. So I think that needs to be reinstated as well, so that people can have education about health at their level. Washing hands before eating, I think we've lost that. Yeah, we used to have that. And we don't seem to be doing that anymore. I don't see people going to wash their hands before lunch in this conference, in any conference for that matter. So thank you for listening.
Thank you, Ranjit, for your sharing. We definitely learned a lot from Ranjit's sharing to us this morning. Our next speaker no longer needs introduction, as he is very much well known to us. Friends, let us welcome again the CEO of IAPO, Mr. Kawaldip Simi. He will save us the day, he will save the day for us. As Kwan Chanuk has mentioned, two of our scheduled speakers for today are unable to come. And Kawaldip, the superhero, will rescue the day. Okay, over to you, Kawaldip.
Thank you very much. Firstly, I must thank the government of Thailand, who was very inspirational. The minister traveled with us on the same flight to Bhutan in Paro. And during that flight, we had lots of discussions on humanized healthcare, about compassionate healthcare. And as we flew over into Bhutan, then the Bhutanese minister, Deshan Wangmo, met us and discussed this issue further, because she had been with us for a long time from Geneva on the issue of humanized and compassionate healthcare. So if I start off by saying that the picture here is a representative of Buddha. It's in Thimphu, it's in the top of the hill. And I'll today present to you the two frameworks, which one is the theoretical part of it, the WHO's Compassionate Healthcare Framework. And the other part is Bhutan's Service with Care and Compassion Initiative, SCCI. And I'll be speaking on both of these. As Sham Said, who is, I've just been emailing him a few minutes ago, he's recovering from COVID. I don't think he would have been with us. So I'm taking the torch from him and carrying on, because he's been working on compassionate healthcare for a long time. He's been influencing this. And during COVID, I think I was again talking to the moderator about this, that our Asia Pacific Patients Congress in the Philippines, the virtual one, Father Jerry came in and he said that we should be restoring humanity back into healthcare. We witnessed scenes that were unacceptable, and to a larger degree, the softer sides of our society, that's the clergy, counselors, social workers, became very important for our health systems. They were the glue that held us together in this enormous onslaught on our health systems. And some of these services were also provided for the health workers. I think a compassionate health care system not only looks at the patients, but it also looks at the health workers as well. How do we include them in? And decision makers as a whole. WHO's definition it talks about when it arises. It's that old saying that I cannot define it, but when I see, I know what it is. So compassion arises when there's an awareness of human suffering. As you say, compassionate healthcare is no room for narcissists and self-entitled practitioners. You've got to be aware of what's happening around you. You have to walk in their shoes. You have to walk in other person's suffering. Then you must have emotional resilience. You can walk away from that suffering, you know, or you can shut it off. Or the worst is you become sympathetic to that, which is the worst thing. You step down and you almost disappear into that own problem, and there you become ineffective. Emotional resonance is keeping those boundaries, but yet being there with that empathy, with that suffering. You know, being there, understanding that, the whole picture where it's coming from. And the two, if you combine awareness and emotional resonance, there's a young man, a young prince in Lumbini, which is present in Nepal, who one day fell into the same trap. Big tree fell on the wall during a storm. He walked out of his palace, which was to keep him away from contact with society. And the moment he started walking the streets of Lumbini, he began to see that suffering. He became aware of suffering for the first time in his life. He saw aging, he saw illness, he saw poverty, he saw death. And he then started relating to that by asking questions. But where he was lacking, I think, was very important. He did not understand what to do next. In his case, I think he went under that Bodhi tree and he spent a long time to find what the action should be. But we should rely on our evidence. Let's fall back into the evidence provided by us, and let's make sure we have that desire to end that suffering or relieve that suffering. We know we can't cure everything. We know we can cure certain things. We can do certain aspects. As you know, WHO always likes some kind of algorithms, and they've said, okay, let's look at this in simple terms. Compassion is awareness plus empathy plus action and plus compassion. Compassion doesn't happen in isolated spots. It's a consistent flowering of things. You know, it's like when the rains fall on the desert. It should be everywhere in your health system. It should fuel commitment and innovation. Because compassion brings about desire to do something, which was again this young man sitting underneath the Bodhi tree working this out. Your full senses should be aware of it. You should be looking at your commitment, you should be looking at innovation, and you must address this as a global health problem. We have to build back better, especially dealing with the disruption of essential services, healthcare workers, burnout, and collective social trauma that we are going through right now. On an individual level, the biggest impact compassion can make is in the delivery of health services, is to recognize that the whole person We must deal with the whole person. The whole person is both the health worker and those who receive the health services. We must bring both together. We can't have one care of the other. One Health, again, has been mentioned. Again, Nidhi was talking about today about environmental impact, about the zoonotics jumping between environment. And I think man, beast, and plant is the issue that's going on. That we are of one source. We have one link with our origin and our genetic material. And therefore, we should be looking at that in total. On a healthcare provider level, you should be compassionate both for the health workers is critical. It should be looking at the well-being and resilience of individuals. And this is, again, one of the symbols we have used on our logos here is the Nautilus. In Asia Pacific and elsewhere, the Nautilus is the vision of symbol for resilience, its ability to bounce back, its ability to endure it. And then again, you're mitigating burnout and making sure sustainably managing healthcare. And lastly on this, on the compassionate healthcare, it's about leadership and organization level. It's to build cultures of compassion. And this we will talk in the next session on turning global patient safety action plans into national safety action plans. How should we build these cultures? These cultures are needed. And it's looking at staff, looking at your colleagues, and enabling organizations to serve populations and maintaining essential. Be well to serve well. If you are ill, you can't serve well. I will now jump to the second part, which is on the service with care and compassion initiative in Bhutan. Bhutan adopted WHO's PEN technical package, if you can search online. And under this program, whenever a person visits a health center, the trigger is to have that compassionate healthcare switch turned on. If they visit for any reason, in addition to receiving that critical acute care they're coming from, we should also start screening them for a host of non-communicable diseases and risk factors such as blood pressure and sugar level. And Dr. Ugan was talking about this yesterday, that they will look at the whole person, bring them in. If the person is found to be hypertensive, diabetic, or having risk factors for NCD, the person is immediately put on a treatment plan. And that's where the action kicks in. And the treatment plan doesn't look at him there. Where are you from? Which village are you? Where are you? Which valley? Who's near to you? Who can give you support? How did you get here? Can we help you get to this? Would you be near to us to receive this treatment? Can we house you? Do you need nutritional support? Do you need this? You start thinking those things and start triggering those agencies in the government. So the government starts triggering those agencies. And you start using that combined effort. You now surround this person with the choices and actions. How does this apply in Bhutan? It starts from the highest peak to the lowest valley, as the minister told us. And the highest peak here was Tiger's Nest. We met at the bottom of this with the Bhutanese health minister. We were talking about compassionate healthcare. Our jitters there, others, and the Thai government people. And we talked at length, looking up. We were at the base of it. We didn't climb to the top because but at the base of it, we were looking up and we were reflecting on this. And the monks gave us a very good show of it. And we had a very good discussion on what compassionate healthcare means. So it means from the top to the bottom, and make sure it reaches all parts. And now at IAPO, we're looking at task, the Task Force for Global Health. This is the focus area for compassion and ethics. We are looking at a new partnership on compassionate primary health care to develop this with them, where compassion meets ethics, compassion meets ethics in global health, very important. We will have another speaker today from APEC, Russell, who will be talking about the APEC ethics thing. And the focus area for compassion and ethics phase brings this compassion and ethics into that center space. Compassion inspires and sustains ethics, and it keeps deep examination of our work. Again, this is an award-winning program. Right? This is at the United Nations General Assembly. Honorary Desho Deshamwangmo, the Bhutan's health minister, was recognized at a global level for this program. It is something that was very important and very humbling that here's a nation who values many things. It's true to the WHO's constitution. It's a nation of gross national happiness. And let's put happiness first. And the minister received this award from them. I'll end at that, and we will take questions, and then we're back on time for 10 o'clock. Thank you very much.
Thank you, Kawaldi, for your sharing. And I have $100 questions to Ranjit and Kawaldi. Okay, what do you think is one main obstacle in attaining humanized healthcare?
I think the first one is, I think there is the pressure that's there at the moment on health systems. We have inherited some before the pandemic and some pressure due to the pandemic. We've got to now dissipate that somehow, and it will require dialogue between everybody. I think this is, I'm so glad here, the government is now inviting patients to come and sit with them, talk to them. The industry who are here are talking to patients. You can see a sea change. We know that this can only happen if we speak with one voice. This is whole of government, whole of society, and whole of patient community talking with whole of industry.
Okay.
Without that, we can't work together. It's together that we stand.
Okay.
Thank you.
Thank you. And Ranjit, please.
Yeah. In addition to what Kawaldeep has just mentioned, I think another important factor is healthcare education for the medical education. It does not have the element of compassionate and humanized healthcare. It's a lot driven towards technology and how you're going to treat a disease. It should be how do you treat people. And there should be, I mean, when we give lectures in universities where medical students are, they tend not to attend because this is not important, it's not part of their exams, so they don't need to worry about it. So that is the other area. So we can start at a younger age for them, like when they are undergoing training, and they can be exposed to what it means to develop a system of having compassion for people. It is there, but it doesn't seem to be utilized in their services. So I think that they need to remove that mask, so to speak, and be able to develop some kind of empathetic communication with patients as well.
Okay, thank you for that. Now, can you give us example? You have mentioned a lot of good things about the position paper of IAPO. So, I mean IEPO, IEPO. So, can you give us an example of like which countries has actually been successful in involving their communities in health and the provision of healthcare, good healthcare?
I could give you examples of when they wanted to start family planning in certain countries, particularly in developing countries. And it was assumed earlier on that mothers were having many children, and at very close, the gap between their children was very narrow. So they were saying that how do you bring about family planning for them and contraception? It was assumed by the healthcare providers that the people, either religious, in terms of religious beliefs, wanted many more children or some other reason. But when they did a survey to find out from the mothers, it was actually the fact that they were losing their babies. There was high child mortality below the age of 5. And they were saying that in order to be able to be secure with more children, at least I will have 2 or 3 children still alive after the age of 5. So that brought about the issue of having vaccines first for babies. Okay. And only then you can allow for family planning for the mothers. And they also complained that the gap between each of the child was not, it was too short a time, and the mothers could not recuperate enough, and they were not healthy enough to have the next child. But they were sort of like, felt that they still had to sacrifice their health to get more children. So I think those were some of the issues that you need to have a survey, you need to get their ideas and what they know, their knowledge, they have knowledge. So you could go to the deepest of communities and ask questions, and people have answers for you. And then only you can plan the services. You cannot do totally top down. So those are some of the surveys that were done in the past to introduce contraception.
Okay, Kawaldip.
I can add to that. Look at Prime Minister Shinzo Abe, rest in peace, what he did for Japan. He started bringing in this issue of improving that care in the community, try to improve that link between the center and the rural communities. And he started bringing in a lot of services to the local level, trying to use digital healthcare to provide care in the home. Another example is Sweden, I think taking from the other side, Europe, where we know that many of their digital programs are now making sure that patients who are receiving chemotherapy have got packs they can wear. They're working with health device manufacturers so that they can take home the packs and sit at home getting that chemotherapy in the home. Additionally, they have moved hospitals construction, made it more community-centric. So many of the Swedish hospitals are now located in centers of shopping malls. You never know who's a patient and who's not. So you never have patients sitting 24/7 in a hospital ward. It's not good for your mental health. The patient can, as long as they've been protected and they know what the protection level is, risk assessed, they can go down and sit amongst you, Starbucks, and be having coffee, and nobody will realize who is who at that stage. And that improves that social care and that sort of. Secondly, I think Sweden has strengthened the role of patient organizations and given them formal contracts to go into hospitals and serve as well. During pandemic, that was what was working very well. I think, as you might remember, when Father Jerry came in at our last Asia Pacific thing, he said that the clergy is now really busy. I think they brought in the clergy, the softer tradition, not only the nurses, the counselors and other services who could be there to address the mental health concerns of patients and organizations. So patient organizations were given service contracts to deliver this. And that's an example, I think. And lastly, I think where South Korea is developing some of those links. And Bhutan, obviously, Dr. Ogan, I think, is a prime example. Thank you.
Okay, thank you, Kawaldip. Just a follow-up question to Ranjit. Because way back in the Philippines, family planning was a big topic because we are, you know, a Catholic-dominated country. So how do you overcome health-related beliefs to implement transformational change in healthcare?
Yeah, I think the maternal and child health care services need to have conversations with the clergy and people in the community because they are part of the community themselves. And they too, I mean, they too have a voice to be able to communicate and to be able to talk about it. I think you need to be realistic and need to be time-focused as to what is happening today and how can you work around things. I think discussions are very important. A dialogue and communication is very important, and it has to be two-way, respect to each other as to what are the practical issues that people are facing, rather than just focusing on the religion says this, but there can be modifications that can be done and they have been done before, yeah.
I think on the other side, I think Zoom, WhatsApp, Facebook has been enormously supportive. I think, as you said, come the time, come the technology. So I would say that Zoom should be given an extra percentage for what they've done. They've helped us to address some of our fears and needs and improve that access to us 24/7. Many of the patients who were isolating were accessing through there. And I think that is very important. So technology should be adopted in that. So some of the countries who are moving away into digital platforms are doing very well for this. They're finding that two things happen. One is that you start taking the pressure away from the health facilities. The second is you're relying on peer-to-peer support. One of the asset-based development models has been that. Use your patients not as cost centers, but as assets and resources. In the Middle East, where we have the Personalized Cancer Care Alliance, we have the same issue there. We are saying we are not cost centers, we are assets. Talk to us, we have got insights. And during the National Patient Safety Day translation that we are talking about, that's what we should be looking at. I'm sure you know everything about your health system, you know where wrongs are, rights are, but has anybody talked to you? No, officially no. So let's open those gateways and make sure people talk to us. We were lucky, I think Aurojit and the Thai minister got on very well. He understood, he was a captive audience on the plane, so he couldn't run away from what we were putting in. So those are the things. Let's get those structures in place, and let's find those opportunities, and let's open up those discussions. And that's where we are here today. Thank you.
I would like to add a little bit about peer-to-peer support, about what Kawaljeet just mentioned. I think when it comes to peer-to-peer support, I mean, in case of cancer, there's huge social stigma, and people hesitate to go and get themselves checked, or they're frightened, or you're also influenced by what happens around you. When people have premature deaths, they suffer before they die, and this is due to cancer. They're also influenced by media. When you see movies, in movies, when somebody is diagnosed with cancer, that guy is going to be just deteriorating, and then he dies. And there's so much of suffering. It doesn't show that somebody lives after cancer. So peer-to-peer support is very important in terms of, I mean, during COVID time, we were doing it, like Reach to Recovery International Program is all about peer-to-peer support. You're trained to give empathy, to listen to the patient, to communicate practical ideas to the patient, but this is done together with the consent and the trust with the healthcare providers, because training has to be done for peer-to-peer support. So we have a proper syllabus where we train the survivors who have completed treatment. They're looking healthy, they're feeling healthy, they're interested in providing support in their communities. And during the COVID situation, we couldn't go and visit the patients in the hospital. So we did it online, we did it by phone. So the power of the mobile phone, you can use it in so many ways. The patient can be in a far off part of the country, and you know, just having a simple mobile phone, and the doctors give us the number and we just communicate with the patient. So that helps the patient to understand the disease, that helps the patient to understand why is it that I need other treatment after surgery? Why is it that, you know, a one-off treatment is not enough? So those are some of the things, and they look at, they're able to see or hear someone who is confident, who is completed treatment and looking healthy. So I'm sure you also have those kind of peer-to-peer support, and that's how we can try and help the public and the community to go for early detection, go for screening, and also be able to understand that treatment has to be done if the person is diagnosed, and be able to you know, adhere to the treatment and carry on with life. And that becomes an important example. Somebody in that village survived cancer and is living a normal life. And
Okay.
the others begin to understand. Just one example is enough. Yeah.
Yeah, we always hear about providing health literacy to patients. But who else should undergo training for health literacy?
In my mind, whenever I think of health literacy, I find that the healthcare providers too need to learn about health literacy, the words that they use, the way they say it. Like sometimes you get a doctor saying that you've been diagnosed, you've got sarcoma. The patient doesn't understand what sarcoma is all about. So simple terms need to be used, and there needs to be working together between patient groups and the healthcare providers to work out on health literacy. But when the healthcare provider is sitting in front of the patient, the healthcare provider must know how to use the words. So I give you an example of, we did a video for breast cancer patients, and where I had the surgeon, the oncologist, and the rest of them coming up with what to say. And they were using terminology that nobody could understand, and was difficult for patients to understand. So we had a lot of debates between ourselves and discussions because they assumed the patient understands. So eventually we came up with something very simple, and you can actually see it online, which is UMMC support and navigation for patient, information support and navigation for patient. We did it in 3 languages. The other thing is language. What is the language of the patient? What is she speaking? Is it English or Tagalog or any other language? So patients have to understand that. The healthcare providers to make sure the patient understands the language.
Okay, yeah, thank you for that. I think, yeah, I have raised a lot of questions and I forgot to ask the audience. Can we hear from any question from the audience here?
No, I just wanted to tell the audience about use of WhatsApp in patient care. So because of distance and because of lack of doctors, we use WhatsApp a lot. We chat also with patient. So when a patient is diagnosed with cancer somewhere far away, I'm informed on WhatsApp. So they send me the pathology, the histopathology report and CT scan report, and I decide what to do with the patient. So if surgery is needed, surgery is first fixed by me in the hospital, and all the blood tests are done in the referring hospital, and the patient reaches just before surgery to our hospital because the distance is far and patients have no place to stay. So once they arrive in my hospital, we don't know what to do, and we have also shortage of beds. So that is what we do with the patients that need surgery. So those that don't need surgery, of course, we immediately either refer or send for chemotherapy. So when we come to chemotherapy, here also we use WhatsApp. So while I'm sitting here, I still get reports of the patients undergoing chemotherapy. So due to shortage of doctors and due to distances and inability of the patients to take care of themselves, so we have resorted to these methods of taking care of our cancer patients. Thank you.
Okay, thank you, Dr. Ogian, for your input. We're running out of time, but I have one last question for our 2 expert speakers. How do you think we, as patient leaders from Asia Pacific, can contribute to achieve humanized healthcare in our own communities?
I think the best way we can do is our involvement, our engagement with the structures at an informal and formal basis, and most importantly to work with others, including the state in this, and create better communication channels and better communication links. Dr. Jeremy Hunt, who was our health minister at one time, he came up with the theory of no blame culture, means open dialogue and discussion, and to admit and find what's problems with your health system, that's what you need to establish. I think open dialogue and access. It can't be us and them. It must be we together.
Okay,
I
thank
think
you.
we need to communicate with the policymakers, the politicians. We need to introduce this topic to them. We need to get the media to interview us, to talk about it, and have healthcare providers who actually believe in this to be also interviewed as to how do they develop this system of having humanized healthcare in their own services or in their hospitals. So at least it is a bottom-up and also top-down.
Okay, thank you. Any more questions from the audience here? Do we have online question too? No? Okay.
Thank you.
Thank you,
Thank you.
Kawaldeep and Ranjit, for sharing your knowledge today. Let us all do our part in achieving or in advocating for humanized healthcare in our own communities. Thank you, everyone, and good morning once again.